Okay, now in the second video on development of the human heart, we're starting with the embryonic heart already looped. And even though it's formed a loop, we still have more or less linear blood flow occurring through the heart. Blood is flowing into the sinus venosus from the vitelline vein on each side, the cardinal veins, and the umbilical vein. And from there, the blood passes into the primordial atrium. From where it's pumped into the primordial ventricle. From the primordial ventricle, blood flows and is pumped into the bulbous cordus, which has a couple different areas. A little further superiorly, we have the conus cordus, and superior even to that, we have the truncus arteriosus. And the blood flows through the bulbous cordus, the conus cordus, and the truncus arteriosus to reach the aortic sac. And from there, it's distributed to various parts of the body by means of the dorsal aorta that we talked about in the last video. And so, in the process of the blood flowing through the embryonic heart, it encounters a few pinch points that are important. First off, we have the common atrioventricular canal, traveling from the primordial atrium to the primordial ventricle. On either side, anterior and posterior, or if you prefer, ventral and dorsal, we have endocardial cushions. These are going to be major players in separating the common AV canal into a right and a left atrioventricular canal. Also, between the primordial ventricle and the bulbous cordus, we have an interventricular foramen. So it's highlighted here in this little dashed illustration, and this is going to mark the site where the left ventricle separates from the right ventricle. And the major thing that allows that to happen is an upgrowth, relatively, of the space between them. The muscular portion of the interventricular septum will develop here and grow towards not just this, what's referred to as the bulboventricular flange, superiorly, but also towards the closing central area of the atrioventricular canal. And that. Okay, so how do we go from the situation where we have a single circuit of a looped heart to the four-chambered heart that we are used to seeing in an adult human? Well, the key is throwing up different walls or septa. And the first thing we do is separate the common connection between the atrium and the ventricle, the atrioventricular canal, into a right and a left atrioventricular canal. Next up, we have to separate the primitive ventricle from the bulbous cordus so that we have a left and a right ventricle. We have to separate the sinus venosus and primitive atrium into a right and a left atrium to correspond to the right and left ventricle. And lastly, we have to get the blood out of the heart somehow, so the conus cordus and truncus arteriosus have to partition themselves and come into association with both the left ventricle and the bulbous cordus to make the left and right ventricles' outflow tracts actually work as the aorta and the pulmonary trunk. So we're going to take each one of these steps in sequence as a separate event, but I want you to keep in mind all of this has to happen simultaneously over the course of about 10 days during normal development. So please bear with me, and remember as you look through these illustrations, to paraphrase George Box, the statistician, all models are wrong, but some models are useful, and hopefully we've got some of the latter going on here. Alright, so if we are hanging out in the primordial atrium and looking into the primordial ventricle, what we're looking through is a hole called the common atrioventricular canal. Now in the process of separating, what we're going to have is two little blebs on the anterior and posterior side, or ventral and dorsal side, develop called the anterior and posterior endocardial cushions. Now the cells inside these cushions come from the neural crest cells. These are a group of mesenchymal cells from the ectoderm that migrate throughout the body. And they do a ton of stuff, but one of the things they do is add to the endocardial cushions and help in heart development. Another thing is they help in development of the face. And facial abnormalities and heart abnormalities, therefore, are sometimes linked by deficiencies in migration or development of the neural crest. Now, alongside these guys, we have little blebs on the right and left side called the left and right lateral cushions that help to impinge the canal a bit. But the main thing that's happening is that these endocardial cushions get bigger and bigger, and they start to encroach on each other and pinch that single common atrioventricular canal into a right and a left atrioventricular canal. And the bigger they get, the more and more they kind of squeeze this shut. And pretty soon, we're left with a completely separated left and right atrioventricular canal as the endocardial cushions have closed the midline of that common atrioventricular canal. And to visualize this, there's actually a very easy way to see what's going on here, and we'll check that out right now. Alright, so in fact the easiest way to visualize the separation of the common atrioventricular canal into right and left atrioventricular canals is to look at the gap I'm making with my hands here and visualize the anterior and posterior endocardial cushions growing closer and closer together until they form two separate openings. And at that point we've got a left and a right atrioventricular canal. Okay, now that we've seen how the endocardial cushions are involved in separating the atrioventricular canal into a right and a left side, let's look at a few other aspects of heart development and how they're involved. First off, we have the primordial atrium here in blue and the primordial ventricle in green. In orange, we've got the bulbous cordus, and here in yellow are our endocardial cushions. And you can see that this is separated into a left and a right atrioventricular canal, which are associating with the primordial ventricle and bulbous cordus. This is important because that's going to be setting the stage for the primordial ventricle to become the left ventricle of the mature heart, and the bulbous cordus to become, at least partially, the right ventricle of the mature heart. So in between the primordial ventricle and bulbous cordus, we've got the muscular portion of the interventricular septum. It enlarges and expands superiorly towards the endocardial cushions. But the important thing to know here is that it doesn't quite reach. It doesn't quite finish the job. It gets most of the way there, but a downgrowth from the endocardial cushions will actually complete the job and create a complete interventricular septum. And that's what we're looking at right here. The muscular portion separates the primordial ventricle from the bulbous cordus, which we can see now is pretty clearly the left ventricle from the right ventricle, but it's completely closed by the membranous portion of the interventricular septum, which is coming from the endocardial cushions, and that's what completes that separation. Now, the next step is the most complicated step, and that's going to be how we get a right and a left atrium from our primitive atrium, or primordial atrium. Either one's acceptable. So what we're doing now is looking at it from an anterior view. In blue, we've got the primordial atrium. We've got it right here, and we've got a couple things entering it. On the left side, the pulmonary veins have at this point merged and fused with each other and are opening into the primitive heart. So the blood from the developing lungs is entering the heart in the primitive atrium. Likewise, our sinus venosus in purple is also dumping into the atrium, preferentially on the right side of it. And that's going to be important as development proceeds. Now if we take a little cut through here, what we see, viewing it from the right side, so if we're over here, where the cursor's at, looking towards the heart, we're going to see that the anterior and posterior endocardial cushions are growing together, and they're bringing this atrium closer together as they seal off the central area of the common atrioventricular canal. And we've got this little bleb. From the front view, or the anterior view, this little bleb is just hanging down in between the midline of the primitive atrium. Looking at it from the side view, it's forming a little sickle-shaped structure right here. And in most text, what's going to be shown is that this grows inferiorly. It kind of stretches downward to seal off the left and the right side of the primitive atrium. What's really happening, however, is that it's kind of formed a sticking point. And it's sticking there even as blood flow enters both the sinus venosus and the pulmonary veins. And the atria at this point are going to enlarge by ballooning out. And they're just going to get larger and larger, and they're going to balloon outward. But this little sticking point, this little light blue area, is not going to enlarge. It's actually going to stay put. And differential growth, and along with the closing of the anterior and posterior endocardial cushions, is going to make something like this happen. It's going to appear to kind of descend or move inferiorly, and we're going to be left with something like this. At this point, that structure is called the septum primum, from the Latin first wall. So it's the first wall in this atrium, and it's basically giving us the separation between what will be the right atrium and the left atrium. And for those of you who've had anatomy, no big shock. The left atrium receives the pulmonary veins, as does this side, and the right atrium receives the superior and inferior vena cava. Now right now we're still getting the sinus venosus in there, so it hasn't quite gotten to that point yet, but the septum primum is apparently descending towards the endocardial cushions, and the endocardial cushions have fused with each other right there. And the gap between the septum primum and those endocardial cushions is called the ostium primum, the first hole. So that's basically the first step in separation of the atria. Now, one important thing to remember is we can't interrupt the flow of blood through the heart or the embryo dies. Blood is entering through the sinus venosus from both the umbilical veins, the vitelline veins, and the cardinal veins. And it can travel through there and reach either the presumptive right ventricle or the left ventricle through the ostium primum. And we've got blood, although limited, coming from the pulmonary veins as well. What's going to happen is that the unthinkable is going to happen. We're going to close the ostium primum. We're going to completely shut this left and right side of the heart, and in the process likely lead to the death of the embryo unless something dramatic happens. So that ostium primum gets closed as the heart continues to grow and that pinch of the endocardial cushions continues, and we're left with something like this. This arrangement is incompatible with further life. So something has to happen, and what happens is that apoptosis in the superior part of the wall of the septum primum occurs. We have little holes develop in it here. You can represent that from the side as well. That's going to allow blood flow to cross from right to left. These apoptotic little regions fuse and enlarge and form a second hole. And in Latin, second hole, the ostium secundum. So, the ostium secundum forms in the septum primum, as did the ostium primum, which appeared and went away. And the ostium secundum is what allows blood flow from the sinus venosus to reach all parts of the heart. It can flow through the ostium secundum to reach the left atrium and left ventricle. It can flow just through the right atrium into the right ventricle. And meanwhile, we have blood from the lungs entering the pulmonary vein to the left atrium and left ventricle. Now at this point, we have a heart that's compatible with life in the womb because of the placenta, but it's not as compatible with life outside the womb because once the placenta is no longer attached, the lungs have to take over. And if we have a lot of oxygenated blood coming from the pulmonary veins into the left atrium and deoxygenated blood from the body entering the right atrium from the body, we're going to have a significant amount of mixing if this big ostium secundum is still there. The way the body solves this problem is really pretty ingenious, and it allows both uninterrupted blood flow from the placenta while in utero and uninterrupted blood flow with the lungs online after the placenta is gone. And the way it happens is that first off, we have to expand the atria once again. And instead of ballooning out, this time, the atria enlarge by pulling vessels into them. The right atrium expands by pulling this sinus venosus into its wall. It literally pulls it in like a glove coming off. And so it expands as the sinus venosus gets pulled in. The left atrium expands by pulling that single pulmonary vein in. And as it does so, that single pulmonary vein pulls its subsidiary veins in, and we're left with something like this. We have, I'll back up for a second here, we have the superior vena cava and inferior vena cava entering the right atrium. Everything shown in purple here is a remnant of the sinus venosus that got pulled into the right atrium. In blue, we have the remnant of the primordial atrium right here. In the adult, that's really just going to form the right auricle, and on the left side, the left auricle. Now, on the left atrium, we now have 4 pulmonary veins because that single pulmonary vein got pulled so far in, colored slightly in pink here, that it pulled its tributary veins in as well. And generally there's going to be 4 of them. And those of you who've studied anatomy will know that there are 4 pulmonary veins entering the left atrium. So we're essentially into the adult setup at this point. Now the most important thing in this process, as far as we're concerned right now with the division of the atria, is that as the sinus venosus got yanked into the right atrium, it bunched up and it kind of slammed into the wall of the septum primum. And as that happened, it formed a second wall called the septum secundum, shown here and here. And that septum secundum has a little bit of a gap in it. So if we look at it from the lateral view, from the right side of the atrium, here's the inferior vena cava, superior vena cava, Everything in purple represents the wall of the sinus venosus that got pulled in, and this little gap that remains through which we can see the blue of the septum primum is called the foramen ovale. So septum primum in blue, and foramen ovale is the gap. And this is the key to everything else that's going to happen, because we've got deoxygenated blood coming in the superior vena cava from the head and the upper limbs, enters the right atrium, and passes pretty unimpededly into the right ventricle. However, the inferior vena cava has deoxygenated blood in it from the abdominal pelvic organs and the lower limbs, but it is also getting a significant amount of blood from the placenta by means of the umbilical vein. That blood is fairly well oxygenated, and it's coming in through the inferior vena cava, and it's directed into the wall between the atria, and it's directed straight into that gap, that foramen ovale. Because there's no septum secundum there, it hits the pale blue of the septum primum, and it's flimsy enough that it gets knocked out of the way. So the foramen ovale allows that oxygenated blood from the placenta to hit the septum primum and knock it out of the way. And that little area that gets pushed out of the way is known as the valve of the foramen ovale. Because of that ostium secundum way up here, that valve is free to move, and blood is free to pass from the right atrium to the left atrium, from there to the left ventricle, and pumped out to the rest of the body. And that is how, in embryo, oxygenated blood from the placenta shunts from right to left to get distributed elsewhere. And from the side view, it just pushes right through that foramen ovale, pushes the valve out of the way, and travels up and then into the left atrium. Okay, that's the most complicated part. The next part is partitioning of the outflow tracts, and it's actually very, very simple, but hard to visualize. So, we've got our primitive heart. Let's take a look at what's going on right here. The common atrioventricular canal is still there. It hasn't separated into right and left. The interventricular septum hasn't formed yet. And way up here in the atrium, we haven't separated into a right and a left atrium just yet. The outflow tracts have to allow blood to leave both the right ventricle and the eventual left ventricle. And they do that by shifting towards the midline and straddling the interventricular septum. Funny enough, the common atrioventricular canal has to straddle the interventricular septum as well, so that blood from each atria can enter its corresponding ventricle. So the outflow tract, formed by the conus cordis and the truncus arteriosus, forms two separate outflow tracts in a very similar way that the common atrioventricular canal was separated into a right and a left. You have a septum form that splits one tube into two tubes. But the tricky thing about this is you've got a swelling up here in the truncus called the right superior truncus swelling, and a swelling that connects to it in the conus called the right dorsal conus swelling. These are opposite a left inferior truncal swelling, and what would be coming out of the screen a little bit as the left ventral conus swelling. This is difficult to visualize. What I want you to think about is that basically you have a growth from one side of this vessel to the other, meeting its corresponding growth and fusing on the midline to form a septum called the aortical pulmonary septum. But this septum spirals, and it allows what's going from the left side to dive a little bit posteriorly to the right into the aorta. And what's here on the right ventricle, is going to pump out into the pulmonary artery, which actually travels more to the left. So this spiraling of the septum is a little difficult to visualize, and I'm going to take a quick second and show you one easy way to visualize it, and then we'll come right back. Now, the division of the outflow tract of the embryonic heart into an aorta and a pulmonary artery is best visualized much like we did with the separation of the common atrioventricular canal. So we have one tube being separated as these conotruncal swellings here and here grow into the lumen and eventually fuse to create two separate outflow tracts. The weird thing about the outflow tracts from the heart, though, are initially they fuse this way, close to the conus, but as we go a little further superiorly, the tube overall doesn't spiral, but the septum inside, the aorticopulmonary septum, does. From there to there to there. And I've got one more way of looking at it that might be a little more intuitive. Alright, hey, we're back this time with more colored tape. Right now we've got this tube surrounded by orange tape showing the distal portion of the bulbus cordis, the conus cordis, and the truncus arteriosus, and a tiny little bit of the aortic sac more distally. And so we've got this single outflow tract, one tube carrying all the blood from the bulbus cordis out to the aortic arches on either side. What's going to happen is that a septum is going to grow into the lumen of this tube, and each of those conotruncal swellings will fuse with its counterpart on the other side to form the aorticopulmonary septum. Now, the trouble is, if these guys just did that in a linear arrangement, up to down, you'd wind up with your left ventricle pumping into your pulmonary artery and your right ventricle pumping into your aorta. So in order to solve that, instead of doing anything sensible, what happens instead is that that aortical pulmonary septum spirals so that the left side here, we'll feed a little wire from our left atrium up here, winds up spiraling so that the aorta from the left atrium travels posteriorly and winds up deflecting a little bit to my right. Now the aorta thereafter will loop posteriorly to the left side, but initially exits the heart to the right of the pulmonary trunk. Likewise, the pulmonary trunk from the right ventricle, right there, zoop, is going to travel a little more anteriorly and push out anterior and to a little bit to the left of the aorta. And so that spiraling of the aorticopulmonary septum is what allows the left ventricle to connect to the aorta and the right ventricle to the pulmonary trunk. Alright, hope that's helpful. Let's get back to it. Okay, so we're back to this slide, and essentially the spiraling of the aorticopulmonary septum allows blood that's coming primarily into the left ventricle to dive posteriorly and wind up in the aorta, whereas blood that's coming into the right ventricle will dive anteriorly and primarily into the pulmonary artery. And as development proceeds, that septum becomes pretty much closed off. Simultaneously, the endocardial cushions are closing the common AV canal completely, so that you have a right and a left AV canal, and the membranous portion of the interventricular septum is growing down from that same area and splitting the left ventricle from the right ventricle pretty much completely. Now, this is really difficult to visualize, but if you can think of this in 3D, this whole structure that I've somewhat poorly illustrated here actually is hanging out and overlapping all the stuff that's right here. I'm not artist enough to draw this overlapping this and make it clear what everything is, but because it's overlapping this, the cells that make up the endocardial cushion are continuous with this gap in the aorticopulmonary septum, and they actually grow upward and complete that separation. And at this point we have a completely separate aorta posteriorly and a completely separate pulmonary trunk anteriorly. Now, just for the sake of hopefully making this a little clearer, I'm going to get rid of the interventricular septum's membranous portion there, and you can see that blood entering from the left atrium to the left ventricle is going to be pumped up and out, and it's going to go posterior to this little wedge of tissue, which incidentally, like the aorticopulmonary septum, comes from neural crest cells, and blood entering the right ventricle from the right atrium is going to get pumped out, and it's going to go anterior to the septum and out the pulmonary artery. And let's take a look at this in a more mature fashion. On the left we've got the mitral or bicuspid valve taking blood from the left atrium to the left ventricle, comes out, gets pumped, and it goes posterior to that septum and out the aorta. At the same time, the tricuspid valve brings blood from the right atrium to the right ventricle. It gets pumped out more anterior to the septum. Right here is where those two tracts have separated completely to the pulmonary trunk. Alright everybody, we are now in the home stretch, and the major take-home for this entire set of videos is in the next couple little slides here. So let's talk about fetal blood flow. Let's put it all into the picture. We start with the placenta, receiving maternal blood, getting oxygen from the maternal blood, and it carries this well-oxygenated blood to the embryo by means of the umbilical vein. The umbilical vein keeps that blood going through the body, through the ductus venosus, which allows it to bypass the cells in the liver. If this is mysterious to you, check out the video I did on the cardinal veins and formation of the venous system. But the ductus venosus allows most of that oxygenated blood to pass through the liver, relatively unimpeded, to reach the inferior vena cava and go then to the right atrium. But before that happens, it mixes a bit with the venous deoxygenated blood from the abdominal pelvic organs and the lower limb. So we have somewhat mixed blood that finally reaches the right atrium. Now once it's in the right atrium, that blood from the inferior vena cava is preferentially shunted through the foramen ovale, pushes the valve of the foramen ovale out of the way, and into the left atrium. From there it's pumped to the left ventricle, from the left ventricle to the preductal aorta, up and out the aorta, and then that blood gets distributed to the head and upper limbs. Meanwhile, we also have blood coming from the head and upper limbs by means of the superior vena cava. That's also going to the right atrium. It can travel through the foramen ovale, but its tendency is to go to the right ventricle, and that poorly oxygenated blood is then pumped to the pulmonary trunk, which then goes to the lungs. You'll notice something. This arrow's small. In utero, we're breathing amniotic fluid. We're sucking amniotic fluid into our lungs, pushing it out, and there's a lot of pressure within the lungs. Now that pressure means that blood has a tough time filling the lungs and pushing out against all that resistance. When there's only air in the lungs, the resistance drops and blood is more freely able to travel into the lungs. Now, having that amniotic fluid and breathing it is actually very important. It means that our muscles that we use to breathe are in pretty good shape and have been working against a lot of resistance by the time we get born and have to breathe air, because Lord knows we're having enough trouble just adjusting to our new surroundings. We don't need to worry about having the strength to breathe if we can help it. So very little blood flow, relatively, through the pulmonary trunk to the lungs, but that blood has to go somewhere. So where does it go? It's shunted through the ductus arteriosus, which comes from the left sixth aortic arch, and I have another video on the aortic arches. Feel free to check it out. This one's kind of the culmination of all of those. And from the ductus arteriosus, the blood is shunted from the pulmonary trunk to the aorta, specifically the postductal aorta. Here's the ductus. After it's postductal, before it's preductal. And the preductal aorta is continuous with the postductal. So we have somewhat oxygenated blood mixing with this poorly oxygenated blood in the postductal aorta, and that even more mixed blood is what travels to the abdominal pelvic organs and lower limbs. And we start this cycle all over again as the umbilical arteries carry blood to the placenta to get oxygenated again. Now one thing to note here is all the purple and blue. As we're developing, our fetal hemoglobin is helping us hold on to whatever oxygen we can get from the maternal circulation, but we're constantly mixing well-oxygenated blood with more poorly oxygenated blood, and during development, our body has to make do with oxygen kind of poor conditions. Now, let's go to delivery. Let's have this baby get born. Let's have the placenta get shut off, and let's have the lungs come online, and let's see what happens. Transition to postnatal blood flow. So we're starting with the prenatal blood flow. First off, placenta's gone. So blood flow through the umbilical vein and umbilical artery ceases. The ductus venosus no longer carries blood to bypass the liver, so it's going to get smaller and smaller and go away, as do the umbilical arteries. I've crossed these out rather than just eliminating them because they leave remnants in the adult body. There's a ligamentum teres hepatis, That's a remnant of the ductus venosus. And there's also the umbilical arteries remnant on the anterior body wall. That's going to be the medial umbilical folds covering the pretty much atrophied umbilical arteries leading towards the umbilicus. But let's move on. At this point, the inferior vena cava is receiving blood almost exclusively from the abdominal pelvic organs, and that blood is exclusively poorly oxygenated. So let's darken the blood traveling from the inferior vena cava to the right atrium, meeting poorly oxygenated blood from the superior vena cava. Now, that's going to travel through the foraminal valley, maybe, and to the right ventricle and the pulmonary trunk. Now notice something. We've stopped breathing amnion. We've spit it out, we've cried a little bit. The lungs are now full of air. Air has much less resistance than an amniotic fluid. So all of a sudden, the pulmonary trunk has a much less difficult time pushing blood into the lungs, and that blood supply gets bigger. Guess what? Blood to the lungs means more blood from the lungs, and that blood travels to the pulmonary vein or veins to get to the left atrium. The foraminal valley was able to carry blood from the right atrium to the left atrium because pressure in the right atrium was much higher than pressure in the left atrium. But that situation changes once the lungs have blood coming and going. Pressure in the left atrium exceeds the pressure in the right atrium, and that valve of the foraminal valley gets shut. And it closes the atrial septum, and we no longer have shunting from right to left or left to right. We have, hopefully, separation between the right atrium and left atrium that's pretty much ironclad. And oxygenated blood from the lungs to the left atrium means that all the blood from the left atrium to the left ventricle is well oxygenated, and likewise to the preductal aorta and to the head and upper limbs. So we're starting to get very well oxygenated blood to the rest of the body. Now, that blood is going to carry from the preductal aorta to the postductal aorta and down to our organs and our lower limbs. Meanwhile, here's our ductus arteriosus. It's still potentially shunting blood between our aorta and our pulmonary trunk. But it's going to go away. And the reason it does is because the ductus arteriosus has smooth muscle in its wall that responds to the heightened levels of oxygen in our blood. And it responds by having the smooth muscle in its walls constrict and contract, and it functionally shuts down. And in the adult, you can generally find a fibrous band marking that, which is called the ligamentum arteriosum. And at this point, we've got the mature circulation. Well oxygenated blood from the lungs to the left side of the heart and out to the body. Poorly oxygenated blood from the body back to the right atrium to get to the lungs. And that is human circulation. I hope you've enjoyed this quick review and talking about development of the heart. It's been a blast. Enjoy.